Good. Giovanna, you may also. Where's Giovanna? Ah, super, super.
There you go.
Good. Now I'm asking you, you have heard already recital 3 of the regulation. Who is first in terms of, let's say, determining success of the whole thing? The patients. It's all about the patients. So patients should have a benefit, and of course the society as a whole. And that's why we start with the patients, and it's a pleasure having Josephine Mosset with us from Cancer Patient Europe, who is giving us now more granular, her perspective on, let's say, what good performance of this regulation should look like and what could be or should be measured. Thanks, Josephine, for being with us.
Thank you very much. It's a pleasure being here. It's my first time here. You probably know Antonella Cardone, who's the usual suspect. She says hello to everyone. So first off, and I actually just discussed this with Valentina, just a second ago, but it's a key point for me. And, if there's one thing I would like, to walk away from this event having shared is, even before measuring success, you have to measure workability. And we that was a point from yesterday, but I think it's extremely important. We need to make sure that this regulation is workable for patients. Because, success, it's not just methodological rigor, but it's, timely, equitable access to innovation, and that the patient voice is truly integrated. That it is not just a ticking box exercise saying, hey, we just push the chair, you're on the table, be happy, right? I mean, because at the end of the day, this is all for the patient. So they really need to make, we really need to gear the system to ensure that patients really see value in this process for themselves as well. I had to fit in this slide, and so had to put it down some thoughts. But what are performance indicators for patients? So obviously timeliness of access. I mean, that goes without saying, and it's really from the beginning of the process. So I put GCA publication, but it's actually from even the EMA, marketing authorization to reimbursement. So are we seeing reduction of time, so quicker access for patients? Then there's integration of patient input. I mean, I cannot emphasize how important this is enough. So, that we make sure that patients are meaningfully involved in JCA and in joint scientific assessments, and that they also are, able to do it without having to transform themselves into health economists overnight. I mean, patients are already living with a disease. They're giving out of their own time for, treatments that at the end of the day will probably not benefit them personally when they join, because it's for many a bit too late, right? So there are tools that exist that, that help patient engagement. And so, for instance, at Cancer Patients Europe, we call for the integration of plain language summaries within the HTA assessments to make sure that patients understand the information they're supposed to assess. That's really important. Then it's about ensuring that you have diverse profiles and you balance expertise and representativeness, right? We want to make sure that patients that are involved in these assessments also reflect the diversity of the population. It's not always the same profiles that end up participating in the assessments. That's definitely a measure of success, that you can have diversity. And then that there's a clean feedback loop. We wanted to be clear, okay, so we provided input and we wanted this input to actually be reflected. And we want, if it is not reflected, to understand why it is not reflected. That's also really important. Integration of patient input, very important. Then use of patient-centered evidence. I mean, many have already talked about it, so I won't go too deep into this, but it's about ensuring that there's real-world data and that there's the outcomes that really matter to patients that are also reflected within the joint clinical assessments. Obviously, very important is equity across the member states. We really also, we see this regulation as a wonderful tool to make sure that we also have better equity, that patients in Romania, patients in Bulgaria, patients in smaller member states see real results when it comes to access And this can be one of the ways that we address this, that we start working towards more equitable access across the EU and not just, in certain member states. And then transparency. We want, I already mentioned this a bit, but we really want to see our input reflected. We want it to be clear that it actually made sense for us to take time out of our lives in participating in this. Because, this is such a, I think that when you work on HD all the time, it's easy, you know what's going on. But I mean, you take a patient, it's like, what is this? What am I participating in? Reactions I've gotten, because I've been reaching out to the patient community, is like, oh my God, what is this? This is wow. Wait, are you sure I can participate? So it's really important that when they end up doing it, that they see the value of it, because honestly, otherwise they're going to not be motivated on it, realistically, and that's really important, that you keep the interest as well. So then, measurement detail. So again, had to put some thoughts, but okay, so what do you measure? Well, time to access, so I said it before, post-EMA, and that's in the context of, the new implementation. The quality, again, use of real-world evidence, and then when to measure. 6 months, I know I'm being very, very optimistic here, but I think it's important to also, push for things. So really when to measure is, we want, it's important to have touch points, but it's also obviously important throughout the HTA cycles of, post-EMA to the final availability. Whom to approach, I won't go too deep here, but I think obviously the main suspects, including obviously the patient organizations. And just maybe to close off my points, really, it's really important that we measure patient input and patient engagement within EU HTA by the impact that it has. It's not just a tick in box exercise for patients. This is their lives at the end of the day. So they really need to feel like this made a difference for them. And just closing off with what I opened with, before measuring success, let's measure workability. Let's measure, that patients are already able to really participate. And, there's a lot to be done. Obviously, we've already made progress, but I already have thoughts on this. But thank you very much.
Yeah, thank you very much. Are there immediate questions? Yeah, Frank Ulrich, the micro is on the way to you.
Yeah, okay, thanks. Thank you very much, Giovanna. I was actually asking myself, and I'm trying to relate that to a remark from Maya earlier today. She mentioned 35 applications out of the second call, and she found that a good result, to say the least. And I'm asking myself, 35 within the stakeholder involvement in patients out of 450 million Europeans. So I'm asking myself, compared to what the first call, the number of patients in Europe. So that's actually, from my perspective, with regard to your involvement, 35, I don't think that's a lot.
No, I think that's correct. And, I've been reaching out to patient groups across Europe, and honestly, the main feedback I'm getting is, look, but this is in English. What the hell? I'm French, I don't speak English. I'm Italian, I don't speak English. So, obviously we understand the limits and resources, and we have to start somewhere, right? But I think, honestly, a big barrier is language. It's major, It's probably the biggest right now. Yeah.
Okay, thank you.
Do you want to comment, Maya?
No, thank you. No, just to say, is it on? Yeah. No, just to say that each of these patients' organizations represent many thousand patients. So, and for the stakeholder network, we have to have an eligibility criteria. We have to manage the system. So we can't have national organizations. So we only that there are certain criteria for the membership, and one of them is that you have to represent, many countries.
Thank you for this clarification.
Thank you for the very thoughtful considerations. Just a quick question. Do you see, is there an existing system today that kind of meets all or most of this criteria, or are we looking to create this new with the EU HTA?
No, I think that there's excellent examples at country level. I'm thinking, for example, in France, patients already do have involvement in early access, for instance. And I think that, it would be really important to build on those experiences, to, build into the system as it is. But of course, I mean, the whole European level aspect, that's unprecedented. So we're working on it as well from our ends.
Any additional questions, inputs at the moment? Then we proceed. As you may know, there is a considerable role of the German medical specialty societies in the German AMNOG system, because they are regularly asked, and that's requested by law on the comparator, and they are entitled to comment on the draft report of EQUIC and in the written and in the oral discussions. And here is where Mr. Wörmann comes into play. He's an oncologist working at the Charité, but he also is the representative of the German oncologists as a leading representative with regard to the AMNOG system. He is sharing the board in the German Association of Medical Specialties, which deal with benefit assessment, and therefore we are very happy to hear your perspective.
Well, thank you very much. First, thanks to Elaine. She allowed me to use my own slide because I wanted to go from the left black to the right green side. But if I would have listed that for the 26, 27 European countries, this would have been completely different in different countries. We have Germany, who are very much on the green side, and other countries like Italy, and other who have less than 10% access to oncology drugs, and that's something which is quite difficult. I have two slides. The first slide is kind of the scientific perspective, and the second one is from a meeting of national societies in hematology, just listing points, just to show how heterogeneous the current situation is. If I put it very simple, from our sides, we have guidelines. Guidelines are not policies. Guidelines guide physicians what to do, and they may probably apply to about 80% of all situations that we have. And there's always been a big discussion in guideline developments. Should we use the highest level of evidence to ask what should be done for the patients, or should we use the lowest common denominator, which is available in each European country? And the basic decision was on the European level that we should ask for the best potential treatment. Then, of course, the request for a procedure like the EU HTA is, if we recommend a drug and a procedure, we want to have it accessible to everybody. And then it's very simple. So my first expectation for the new procedure is that we have the green point, which is access to all approved and recommended drugs. It's quite important for us, but basically we talk about the same data, but they're interpreted in different ways. We just usually have only one clinical trial these days. We don't have two or three. Sometimes after a while we have a meta-analysis, but mostly we have those high-quality clinical trials. And of course, I think it's very important that the scientific consultation that we are having on all those who are involved in those clinical trials are the same that also consult the EU HTA process, so that it's one language and also at least usually the same quality of assessments. Patient-relevant endpoints have to be assessed. That's the joint clinical assessment. There's some considerations that may vary, especially in oncology. If we go back 20 years ago, no question that overall survival was the best treatment, was the best parameter for everybody. Now we have many chronic diseases where people have a normal life expectancy, and then overall survival is no longer the most important point for these. It's quality of life. How do they live? Not only how long do they live, and some indirect parameters or surrogates like minimal residual disease are discussed. Maybe easier to access early drugs, particularly that's something to be discussed. Then, of course, the national respective standard has to be respected. You saw in the previous session, the whole model that we now are discussing is basically a comparator model. So we compare the new one against what's the current standard. If you consider what I just said about the extremely heterogeneous population in Europe, then the comparators are different, because now if I look multiple myeloma, we have, for relapsed multiple myeloma, we have 8 different options to be treated for a patient who is relapsed in myeloma. But in many countries, there's only one option, or only 2 options. So if we discuss it, we have to respect the national standard, otherwise we will lose these people. And of course, we need maximum transparency to include all stakeholders. And this was kind of the national, society perspective. Robin Dosberg has organized together with me 7 weeks ago a meeting of all European hematological national societies. Next slide, please. Under the level of the European Hematology Association. And these are just some points which they summarized. Very importantly, of course, the first is easy, mortality and morbidity should be reduced. But for them, in many countries, there is no stable existing cooperation between stakeholders. Like those who decide about access to drugs and how to finance the drugs have no direct contact to like the national society or to patient organizations. It's a luxury which we have in our countries, and there are some who are fantastic, but basically in many of them, also on the patient level, it's individual engagement and not really a strategic engagement. Very important point in this meeting in The Hague was many countries have on the national society and the scientific societies no education about HTA. They don't know what it's about. They don't know that there are different values to be contacted. They are not trained on the strategic approach to having these discussions. So education about HTA is quite an important goal, and I think that's something which should be done within the next couple of years. The prioritization of endpoints, I already said. And the very last point, of course, it sounds like an industry perspective, but of course we are very much aware that in many oncological indications, we had parallel development of new drugs. So if we compare something, and we compare to an old standard, it's not the current standard of knowledge. So we have to look at real-world evidence, we have to look at registries, and we have to look them in the best way, which is to include many patients, probably all patients which have been treated on the European market. If we compare like the German perspective to other countries, we are very far away from having good registries. Usually they're not even included in GHA assessment, but I think the future also for Europe will be to summarize data, to collect these data in a high quality way, and then use those data also for future studies. We probably can use synthetic clinical trials, we can use AI to have better idea of how current drugs are working. And so I think we also have to look for the future. So yes, the clinical perspective is to look at what we have now, but also to look for the next 10 years and develop what we have to probably a faster approach to develop and access to new drugs. Probably I apologize if it sounds like a summary of very different points, but I think if we look at success, we have to look where the people are these days, and then the perspective of the national society is very different in the different states. Thank you for your attention.
Thank you, Bernhard. I look around and there's a first comment or question already.
So I have one question, which is related to stakeholder engagement frameworks. So how can structured stakeholder engagement framework ensure regular patients' reported outcomes and caregiver perspectives, that they are systematically prioritized in joint clinical assessments, especially for orphan drugs and advanced therapy medicinal products? Thank you.
Do you want to answer this? No, I'm sorry.
The question was to you, I think, but both of you can answer.
I can start.
Yeah, that's great. And then you follow. That would be great. Thank you.
In this discussion with the National Society, we saw that there was different priority in the patient, also the doctor's assessment of what HTA gives. So I think my simple answer would be, we expect the assessment to evaluate all endpoints. And the appraisal then has to be done on the national level, which may be different in that approach. But I think it's very important that we have all potential endpoints, which of course are summarized in the clinical trials, the major endpoint which determines the power of the clinical trial, but also our secondary endpoints. And as discussed in previous discussions, we feel that patient-reported outcome should be the most important one, but the instruments that we have these days are usually not really useful for that. Like, it's not the distance between the questions that are asked, like every 3 months, is much too far away. You should use digital tools to ask patients very early on. And then if we have a higher quality of this data, I think we can prioritize that endpoint, like patient-reported outcome. That would be my clinical perspective.
Thank you. And your perspective?
Yeah, so maybe just to say that I don't know if I understood your question correctly, but in the legislation there are specific time points when individual patients and clinicians are consulted. And there's a whole process that the Commission identifies through the stakeholder network, through the EMA, a list of potential patients and clinicians. Then we check their conflicts of interest, and then we present this list to the Joint Clinical Assessment Subgroup. They then choose one. So I don't know if that's what you meant, but there is a structured process, and this is for all. I mean, it's for the oncology products, it's for the ATMPs, it's for the orphans, but so it's creating a framework where you will have the systematic consultation of individual patients, and this is why, to Josephine's point, it's really important that we make this a meaningful participation. And so we take on board your points, but it's a learning curve because, as you said, for a lot of patients, I think at the moment people are excited because they don't know, and that's why it's really important that we really follow through. They will be compensated as well. So we're doing all we can for the enabling conditions, but I understand that they will probably need a lot of support in the beginning and also this kind of feedback loop so that we can constantly improve the work. And this is something that we are working very closely with the consortium of member states to really make sure that this is embedded in the whole process.
A question by Jörg.
I have one question on this line. So I appreciate very much the systematic approach and also that we look into conflict of interest. Of course, we have to be transparent. That's the world we are in. But do we equally examine, let's say, level of expertise, equally systematically, in order to ensure that, let's say, how should I frame it somewhat drastic, that not the blind speak about the visual environment, so that really the best experts in the field are commenting on the most recent innovation in ABC. So what do we have an equal approach to this one?
Yeah, absolutely. And this is why it's very important that we go through the professional associations, we go through the patients' organizations who know their people best. We also ask for a CV. So we ask for this expertise to be carefully done, and as I said, this has to be very transparent because you're right. I mean, you can, all of this can be will be questioned. So we need to, and that's why we need to do it structured. We need to have this all transparent. The patients will not be published because of data protection. So you will not have the name of the patients, but you will have the name of the clinicians who provided expertise with their declaration of interest.
Bernhard, on this line?
I understand the structure, but I previously discussed, I started very explicitly with guidelines. Guidelines are no longer single person-based guidelines. It's just not adequate anymore. So if we look at an asthma and EHA guideline, we have 20 to 30 people who are involved in the guideline. So we basically have a common effort, a network effort. So I think it would be very helpful if we could use these networks as experts also for this procedure. I understand this is not very easy, but I think single expert is no longer up to date.
Oh, God. I think we...
Okay, we can move on. All right. Well, if we can move on, then it's a great pleasure to introduce Mr. Berntgen, Michael Berntgen. He spent his whole professional life, almost his professional life, in regulatory affairs, starting in the industry and moving to the market authorization agencies. And since almost 20 years, he is with EMA, if I understood it correct. And his present job as heading the Department for Evidence Development, he does this job for 5 years, I think. So welcome, and we are happy to see your perspective.
Excellent. Thank you so much for the introduction. Well researched, my CV. And really a big thank you to the Academy for inviting EMA to this conference here today and to this spring convention about approaching performance measurement for EU HTA. And I think looking back at Jörg's scene setting in the beginning, it really feels the right time to look at how can you measure impact and how can you measure efficiency, effectiveness, because as you also heard from our Australian colleague, it will take some time until you agree on all the principles here. So I think it's a good discussion to start here. And then at the same time, you may wonder, so why is a regulator sitting here? It looks a bit odd. It's about the HTA system, isn't it, that's been evaluated. So the regulator is a different decision maker, isn't a stakeholder, is somebody who is, of course, also makes certain decisions. But then on the other hand, we are working in the same space with similar structures. And you will also have seen that in the European Medicines Agency's network strategy to 2028, there's a dedicated chapter on accessibility. And one of the goals in there is to support the implementation of the HTA regulation. So there are, of course, links, there are, of course, activities we do together. And my contribution here, therefore, today will not be on what HTA performance indicators would be. That wouldn't be appropriate. But I can maybe share a couple of observations and a couple of perspectives from the regulatory perspective and our experiences. Because as I was saying, we're having similar structures, we're having similar objectives because we're working in the public health space. So if I look at the HTA network, and this is what you guys are all familiar with, it is now in application since January 2025. It is driven by the member states. It brings together the member state expertise in HTA, and it is coordinated by a central structure, a governance body, plus a secretariat. Right, and if you mirror this to EMA, then EMA has started its work in January 1995, so 30 years earlier. And let me emphasize this, because it's extremely important to appreciate that, of course, from a regulatory side, we have been on a journey for 30 years, and we have evolved in a certain way. And I think that's something really, really to keep in mind, because I do sometimes hear parallels being made, and we need to be fair also in this context here.
You quadrupled your staff during that time.
Okay. But then also, if you look at the structures, we got European medicines regulatory agencies which are working in a network, which we call the ERMN. And this is really our body of different national competent authorities coming together. And I'm speaking here, of course, also closely watched by Rui, so I need to get my things right here. And it's coordinated by the European Medicines Agency. And the European Medicines Agency has its committees, as you know. That sounds familiar. And it's an agency which provides a secretariat, which started as an administrative and procedural secretariat and has at some point become a scientific secretariat. So I think there are elements of similarity, but there are also clear differences. So all the points that I want to make here are really more like, what are we doing? How do we measure our performance? What are the domains here in this context? And I want to come back to the principles that Maya presented on her first slides. It's about high quality delivery. That we definitely agree with, also on our side. It's about transparency, trust, engagement. These were, again, shared principles here. It's driven by member states, also on the regulatory side. It is about scientific expertise to be used. And it's about progressive implementation. And that's why I was making this reference to the different degree of maturity maybe at some point. So all of this being said, And there were many ideas already what could be performance indicators. And Jacqueline, you were presenting some of these. Let me just say, in view of faster and wider access to new and more effective medicines for patients, which is, let's say, the overall objective of the whole regulation, what could be domains to be looked at? Domains to be looked at, the first one is, of course, standardization of methodologies and data requirements to enable joint work. That's an area to specifically be looked at because these guidances are extremely important for all parties involved, and that delivery is so important. And I'm extremely grateful that Rui already had on his slide today a document which we published yesterday afternoon jointly. I got a paper version here because I'm a dinosaur, so this is a short document here, but I think it's really something, and if you're traveling back home later, if you haven't read it yet, it's just a few pages. Take it on the flight or train, read it, not when you're driving, of course, and read the paper and get a perspective, a joint perspective, regulatory HTA on what are evidence needs, what is robustness of evidence from our perspective, and how does one manage uncertainties? Because these are questions we're having all, obviously. And I think the shared position in here could really help also developers to get some insights. And I would expect it stimulates a bit of debate, but maybe not today. Let's read first, okay? The second point is a competency framework to be developed, a competency framework and training programs to be developed. And again, this was very much echoed in previous discussions also by Niklas, how the framework is building up these competencies and capacities. The third area is expertise sharing across countries, across HTA bodies. What we have in the regulatory field is multinational assessment teams, where we put together different assessors from different countries to work on one file to really optimize the involvement of expertise across the medicines regulatory network. A fourth area would be, of course, classic process PIs on delivery. Like what we have in the regulatory network, the national competent authorities are being measured whether they submit and provide their assessment reports on time. You know, very classic nitty-gritty process details, of course, is one of the PIs that you need to consider. Tools to enable efficient working is the fifth area I would give you. And of course, here's the HTA-IT platform. If I could just look at this, and from a regulatory perspective, we have IRIS, our tool, which is going to be supporting all this work. The sixth area is really around building transparency and trust through the operations. And here, an area where I would really also say the HTDs, the applicants, are to be asked to contribute to this. And they're also going to be measured, right? So it's really a measuring on all sides. It's not a unidirectional measurement, but it really takes everybody on board. And the seventh and last point, because you're getting nervous, I know.
No,
but the seventh
really
and
not.
last point is really about engagement and visibility internationally. What I've heard so far is a lot about European coming together, etc., etc. But I also heard in some introductory remarks, the geopolitical arena has changed. And I think working together also allows the voice of Europe, of European HTA, to be heard very strongly in the international context. And I think this is something to be looked at. Again, from a regulatory perspective, this is very important for us. You hear about reliance, etc., etc. So I could just echo this maybe as a domain and can suggest for consideration from a regulatory perspective. So this being said, to close, I think the network that's been created is more than the sum of its individuals. That needs to be something to be really, really enshrined in thinking, and therefore also being looked at from different perspectives. And one needs to ensure that one robustly delivers on the public health ultimate goal, which is enshrined in the legislation. And with those reflections from regulatory perspective, back to you. Thanks.
Yeah, thank you very, very much. And I was not at all nervous. I was waiting for points 8, 9, and 10. Unfortunately, you had only 7. Well, I interrupted you with, or said something about you quadrupled your personnel. What I mean, I think that's something important. You demonstrated also 25 years of capacity building within EMA. I mean, just one catchword you describe the process from moving from a technical secretariat to a scientific secretariat. Everybody knows what this means. And I mean, regarding to this, I think one of the real challenges is how will capacity building work with European HTA. I mean, we are quite in the beginning. I really admire what you do with your small team, but I mean, this cannot be the future for European HTA. We must do capacity building also on the central level. It cannot all be GBA and us and all these agencies who always have these capacities, and they have such a small capacity in the European Commission. Therefore, thank you very much for this analogues, which are really, I think, lessons which we can learn. And I wonder whether there are questions. There are 2 of them at least already. Go ahead.
So, I mean, it's not really a question. It's just an echo of what Michael was saying before respect to the competency framework and capacity building. So for sure, capacity building and competency framework are a key, crucial aspect of the implementation of the HTA regulation. It's not just producing and adopting documents, guidance. We need to have also the capacity. And Rui this morning mentioned that one of the initiatives of EDO HTA agency group is Hug Inside. Hug Inside in reality is a service tender contract from ADEA and DG Sante to increase the capacity building of the HTA bodies in Europe. And what we are doing now is exactly to map the competencies needed for the HTA joint work in Europe and to map the gap existing in different HTA bodies in Europe. So our objective is to support HTA bodies in the medium, long term to build a really sustainable system. In the next 1.5 years, we have the objective to train at least 600 assessors and co-assessors all around 27 member states.
It reflects very well to an online question. And again, online, please keep your questions. Marcus Dincius asked, let's say, HTA training, education, who, from when, what is the plan on this one? Exactly what you mentioned. I don't know if there's anything in addition to comment from your side. Yes?
Yes, thank you. Yes, I can perhaps add a little bit on one point that Michael mentioned, which is the added value of the network. I think it's very important here in terms of the capacity building that we look into all the elements that are not just one of the elements. Of course, the capacity building is essential, but it's also essential that we are harmonizing the procedures, that we are making the procedure more efficient, that you are able to share the resource. So I think is the overall of these elements that will at the end make the difference. But of course, I don't want to say that there won't be a need for the evolution. Certainly yes, and I have praised many times Maya for the work that the Commission together with us has been able to do. But I think we have to put all these elements together, because the response or the evolution will be lying on all these these aspects. That I very much agree with Michael when we say the sum of is not just the sum of the ones that participate, but is the added value that results from this cooperation. Jörg, back to you. Thanks.
I have also one question. So related to HTA evolution. So let's change the perspective a little bit from, let's say, short term to middle term and long term. So what are your expectations in terms of HTA evolution? And how can we ensure a well-balanced approach between immediate HTA policy implementation and long-term planning. So let's say 10 until 50 years.
Oh, thanks for the question. I think this is a really, really pertinent one that colleagues will be looking into, who are actually in charge of HTA and who really need to make sure that this system evolves and there is this ambition. And then yet again, it wouldn't be for a regulator to comment on what this evolution should look like. I think this is why it's great to have the strategy that Haag is proposing and is developing. We would, of course, stand ready to support any of the work that's been there at the interface between the two processes, which at the same time need to be conducted within their own remit and by respecting the boundaries which are also being led by legislation.
Thank you.
Marlene Gilmark from Beijing. I just have a comment, and that is on these boundaries, because HTA is a definition that came out of a wish to work together across countries and to be able to share work. So there's a certain definition of HTA that was agreed upon across member states. But I can't really see the difference between what you are doing at EMA and what is part of an HTA.
Again, great question, because I think this is such an important and fundamental discussion. If you look at it from the chain of decision-making that leads from early development, if you look at even clinical trial application, etc., all the way through to access, there are certain steps. And these steps do, and I think rightly so, include certain boundaries to activities to be looked at. And if I just compare now the two, which we are alluding to in your question, one is to have a precise look at the benefit-risk of an individual medicine. And the benefit-risk of the individual medicine is what regulators are to be looked at. And the legislation for regulators is very clear. It says in our founding regulation that we have to come to our conclusion to the exclusion of economic considerations. That's the original language. On the other hand, once a benefit-risk is established, it will need to be contextualized. And this is how I understand, because I'm not an HTA, but how I understand the work of HTAs to contextualize this medicine with alternative treatment options and then to come to a conclusion which allows the subsequent decisions to be made. So I think it is quite clear that there are different ways to look at certain degree also of evidence. And this is also where I agree with you. We have one set of evidence often in front of us. And therefore, it is so fundamental that developers are getting ready to design their program so it can address different questions from different decision makers.
Thanks for this one. And I fully get it. I fully get your final, let's say, a recommendation to the developers. Marlene's question, of course, has a point. Risk-benefit assessment is also a health technology assessment. Depending, it's an assessment of a health technology. We know, we understand the different remits, of course, but just in terms of the language, it's an interesting point to challenge the language behind this one. François Meyer.
Yes, François Meyer from France, before HAS and now various activities as a consultant, particularly in a project called Reward Evidence for Decisions. And you mentioned the patient representative, in the fact that the use of reward evidence would be one of the criteria for assessing the success of the regulation. In itself, it's not part of the activities, but there are mentions of the real-world evidence, is the methodological guidance. There is also the joint scientific consultations when you can ask for post-launch evidence generation, for which this real-world evidence would be part. There is a lot of activities at the level of EMA concerning real-world evidence. So what would be your comments through your three of them, considering what would be necessary to achieve in the term of a better use of real-world evidence within the HTA regulation?
I hope I got quite what you meant. Achieving. So I think, like, for instance, I'm going to take maybe an example of like one thing that we saw. So when we saw the methodological guidelines that were published for, you know, the assessments, you know, it wasn't clear how alternative evidence was going to be considered. And that raised a lot of concerns for us, especially for, like, for instance, ATMPs, where, you know, the gold standard, the randomized controlled trial, is not always not only possible, but not ethical. Because you consider pediatric cancer, it's just not ethical, right? And so this is where we were calling for more clarity on how do you consider these other types of evidence, and specifically how that can be achieved. I'll be honest with you, that's a bit outside of my own remit, but it's something that we want to see happen. You know, we want these other sources to really truly be considered. We understand the limits, of course. I mean, we understand that the gold standard is the gold standard for a reason, but it's just, I think, you know, you were talking about contextualization. I mean, this is part of it, right? I mean, you need to contextualize assessment, so real-world evidence works towards that, and so I think that that's where we wanna see it happen. You know, so I mean, we were mentioning prompts, we were mentioning other sources, so you know that this is how we wanna see it happen. I hope that answers your question.
So we go on to the next discussion when when it arrives to the country. Just one additional comment. Online, there was a commentary. I just leave it with a commentary that this conflict of interest situation might be a challenge for smaller countries where, let's say, there's only one expert or whatever, and this or he or she might be excluded to conflict of interest, and they still need to run a national appraisal in the end. So this is a challenge that we have to be aware, and this was mentioned online. So, as I said, in the end, it's about the member states and, let's say, what comes down to the member state and the implementation in the member state. And it's a big pleasure to have Giovanna Scroccaro with us. She's a pharmacist by training, and she has a long-term history in public health in Italy and is heading, let's say, the pharmacy division in one of the Italian regions. As we know, in Italy, the regions have a lot of power and influence in the whole system, and she was heading for many years, my understanding, also the group of hospital pharmacists across Italy, so in charge in the end of ATMPs and advanced onco drugs, because this is of course all administered through the hospital. So thanks, Giovanna, for being with us and giving us, let's say, this perspective, the national perspective from Italy on the whole thing.
Thank you very much. Thank you for the invitation. Before talking about the key point performance, I would like to show you two slides, only two slides. This is a slide which shows that there is a big difference between the countries in the access of cancer medicines. Is an update of 2023, and it shows that only in some countries the people can have the medicines without significant out-of-pocket expenditure. But in many other countries, lower, middle and low-income countries, the majority of patients don't have access to the new oncology drugs. The second slide shows that there are big difference between the European countries in the access of medicines. You can see that Germany is the first country in terms of percentage of medicines reimbursed accessible with respect to the medicines approved by EMA, but then you can see that there are many countries where the medicines don't arrive to the patients they can use in those countries. And I think that we have to reflect about this figure. Do you think that the countries on the right side of the figure don't use medicines because they don't have access to HTR report or because of economic constraint? If the answer is because they don't have access to an HTR report, we will see in the next years this figure will change in a better way. But if the problem are economic constraints, I think that there is the risk that this figure will worse because of economic constraints that many countries that actually don't have, will have in the future. And I'm talking, for instance, for the economic constraints that in Europe we will have many countries. Italy is one of these. So I will try to briefly explain in few words how is the assessment process in Italy. In Italy, the responsible for the reimbursement and pricing is the Italian Agency of Medicines. There is only one committee, 10-person committee. I am one of the 10 members of this committee. And the process is this. There is a first phase where the unmet clinical, the three items utilized in France, in Germany, are the same. We have to define the unmet clinical need, the added therapeutic value, and the quality of evidence using the grade system. After this first phase, but immediately after, there is the economic assessment in the same agency, in the same place, with the same committee. And the two decisions are there is no added therapeutic value or there is an added therapeutic value. If there is no added therapeutic value, the law says that you have to give a parity price. So we have to identify the right comparators and giving a price aligned with the comparators. If there is an added value, we start with another way to work. We evaluate the cost-effective analysis, we evaluate the ICER, but what is particularly important, we evaluate the economic forecast over the following 3 years after the pricing reimbursement. So this part, the evaluation of which we be the expenditure of the medicine in the following 3 years is one important part of the process which influences the decision. If you look at the HTR, I think that for us, for Italy, will be very important to have the outcome endpoint selected from the HTR report and the comparators, because in this point there is a long discussion with the pharmaceutical industry, because for the agency the comparators are some comparators and the important outcome are some outcome, but for the industry they say that there are different outcomes. Important as more important, and in the discussion the oncology presented, for instance, an example how the progression-free survival now is important, at least as the overall survival in some oncological situation. So this discussion about which is the correct outcome to consider and which are the right comparator, I think this discussion could be really use the HTR report. I think that could be very useful to have this information in order to cut the discussion, in order to reduce the discussion. You know this discussion is very complicated because if you look to the slide, you can see that in some cases we have only one comparator. Is very easier, the comparison with the price. But in many other situations, the PICO itself presents many possibly comparators. So the discussion must be more complicated. In any case, I think that this part, only this part, I think that yesterday and this morning, there are many expectations from HTR report. Many people say probably with the HTR report we will reduce the time for reimbursement and will we have more homogeneity. But I don't think that it will be this the answer, because I think that we will reduce the time dedicated. The national agency will reduce the time dedicated to the analysis of evidence, but the last part of the process, evaluate if there is a clinical value or not, and how we can spend for this added value remains in the member states' power. So I don't think that the situation will tremendously change, but this part will be utilized. So you can see that from the point 3 and 4, there is the negotiation, and we will utilize the GHR report. At the same time, the region in Italy are in charge to purchase the medicines and to identify which hospital can treat with that specific medicine. I think that the GHR will be very important for region to anticipate the evaluation. Obviously, one region in Italy can't buy a medicine if the process in AIFA is not finished. But I can anticipate, I can start before to understand, to know in advance the characteristics of the medicine. And I think that this fact can reduce the time that now we have from the approval of agency and the purchasing from by the regions. Now we have some differences in the different Italian regions. Some regions are more proactive and immediately buy the medicine just after the decision in the AIFA. Some other regions are not so efficient. But I think that the GS report can help in this sense, because you can know in advance the characteristics of the medicines. And this is my last slide. I have identified only 2 key performance indicators. I think that the comparators, so the level of agreement between the comparators identified by AIFA and those identified by the Health Technology Assessment Report, if they will be very different, this means that the Italy will not adopt the HT report. And the second is the outcome, is the same, the level of agreement between the endpoints considered by AIFA and those considered by the HTR. Thank you.
Thanks very much, Giovanna. Great insights into the Italian system and how the European system relates to this one. Any questions on this one? Also, any comments on, let's say, other national systems? Montero has a question.
I have a general question. Niklas this morning explained us that everything that happened after the GCA is the responsibility of the member state and therefore should not be part of the KPI for EU HTA. And when I listen to everybody here, what is critical is time to access and level of access. So can we dissociate EU HTA and assess EU HTA intrinsically? It worked very well and it delivered very well and in time, but time to access is prolonged, number of products available is decreased, but this is not my problem. What's your view on that?
But thanks, and this needs to be said a number of times because I think the system has an intrinsic challenge, at least communication challenge. But I think, Giovanna's and my own presentations were quite aligned, actually. We see a number of opportunities and benefits of the new joint system. We can take away a number of time lags. Hopefully they're not too common, but when we are scrutinizing evidence, performing methodological exercises and so on, they will become leaner, more unified, better, higher quality. But once again, we need to manage the expectations. That is a fair expectation, and that's something we should focus on in this discussion. We are not trying to hide away from that, and that's quite a big undertaking. But to say that if patients in country X, Y, Z, and W doesn't get more very expensive cancer therapies, is probably not to blame HTAR for. That's probably another reason then can be managed. So another way to put it is HTAR is a very good step forward, but it's not the only one we need.
But what's the promise by the legislation? I mean, the legislation promises faster access. I mean, more broad and fast access. I mean, if that's the case, then one should ask, isn't that the most relevant indicator at all? If it's the goal which the legislator who made the draft, the legislation himself put as his priority goal?
But nowhere it is in this aspect without respecting the member states' need to manage the sustainable system.
Yeah, okay.
I think when you read the EU HTA regulation, the two first points that define the objective are, number one, to improve access, and number two, to improve the single EU medicinal product market. And if the EU HTA regulation doesn't allow to achieve this objective, either we have to change the objective of the law, or we have to change the content of the law. Maybe the solution is to have a single EU procurement and not an EU HTA. There have been no HTA when we acquired the vaccine. We didn't have a common HTA. We had the procurement. Is the solution through the procurement or the solution through HTA? If HTA is not able to improve time to access and quantity of product accessible, and the law aims for that, then maybe there is a discrepancy between the two, and we should reconsider another law with the ultimate objective is to improve access to patients.
Does anybody of you four here in the front want to react to this discussion?
Ruiz Santos has a comment, and
okay,
then I hand over to you.
No, yes, I want to make a comment. I'm not sure if I can not answer you, but also I do not agree with your conclusion. First, I want to compliment Giovanna, because I think you made it very clear. And also, I think you said one thing which is very important, is the added value of the European joint clinical assessment. And I think this is the most important thing that we have to agree, because if this is the case, I'm certain that this will support and help in improving the process. Of course, it will not do a miracle to resolve everything, because as Nicholas rightly said, at national level, we still need to look into all the other aspects that also Giovanna very clearly expressed. So I think we have to be positive vis-à-vis what is the benefit of having. Yesterday, I think we said that dinner. So we have the spectrum, now we have the regulatory part, it's already very well harmonized. It's European level that is responsible for. Now we are moving a little bit more. So now we have the joint clinical assessment. I mean, we called it HTA. I also agree. It's just probably a definition. But it's the contextualization with the comparative element. But then having this report that if we ensure that is of high quality, that is the right level of evidence, that is an important document that we can use. I'm certain that, as Giovanna was saying, that this will be impacting positively in the access. So it will contribute to access. It will contribute also to the timing of access. Our systems are very similar, and also our agencies are very similar, Giovanna. So when you put this phases, exactly how we do. The only difference we have, we are a smaller country. We don't have the regions. But even though without the regions, still the different hospitals also do different ways of giving access to the medicine. So my word is we should be positive, because I think if we work together and if we are improving the level of the work, I think this will help very much the system at national level as well. And as I said, we need to monitor that. So I would, coming back to your previous question, so we need to look on what we do at the European level, but also what we will do at national level.
I think one more question, and then there are two more online questions. And with this one, I would suggest then a closing round. Frank Ulrich?
Just a quick comment. If I hear what you just discussed and compare that with our German assessment approach, this sounds that HDAR is a surrogate for better access, which would be the patient-relevant endpoint, and that link is simply not established and not validated. That is what I hear. Thanks.
And unfortunately, it's a single-arm trial, therefore...
It's a single arm on top of that, yeah. It's a single arm with a surrogate endpoint, yes.
Maya had a point to this one, and then we do the final round.
Thank you very much. I just wanted to also mention in the graph that you showed, on the right side, the countries that don't have access, a lot of that is also to do with the market launch. So here I would like to ask the companies, now the difference is that all of the member states will have the data. So are the industry now going to be more proactive and go to the countries that they might not go to normally? Because this is now as well, I would say, a disruptive issue. We're doing something that doesn't exist at the moment. So I think that issue also needs to be taken into consideration in your graph, where we show that access is not just about not being able to pay, but it's actually not about the product being in the market. And I think this is something that we could definitely look at as well and monitor.
As companies are addressed, I would like to ask the representative if,
At least let me try. I think I would agree. I think this regulation has to contribute to a better access situation for patients. There are many other issues, and it's certainly my industry association that has worked during the last couple of years. It has clearly worked up the issues, the various issues that are out there that we need to resolve. And I mentioned this earlier, we cannot resolve them from a European level. They are rooted in the specifics of the healthcare system. We've developed solutions for this. And I think we are working also in a legislative environment where we try to bring solutions for this specific topic. The pharma legislation has tried to bring we could say brute force element into this, but there's other areas where we work with other stakeholders, for example, the WHO Europe, which has also created a framework to think about the specifics in specific countries, small countries. The situation in small countries is different. It's a different engagement. It's a different need to solve these problems. We are committed to work on those topics, and we do work on those topics in quite a number of parallel legislative processes now. What is the question?
The question was, does joint HTA contribute to the willingness of the companies to provide access to more, to provide products in more countries in a quicker time?
I think it certainly has the potential to make it easier for companies to navigate already quite complex HTA systems that exist in some countries, that exist sometimes poorly described, sometimes they don't. So the idea is to simplify this path to the market for companies. I think that's an important step also in our business case for bringing products to market. Thank you.
Thank you so much. Two more online questions, and with this one I would then suggest a final round of the experts. The one is from Carol Longson. How best can a EU-HTA JCA community use the experience of the development of EMA over 30 years to expedite both the scientific and procedural performance of JCA? This probably goes to Michael. And then Latvia, Dr. Cukauskas, asking about, let's say, isn't there a need of better direct communication between EU policymakers and national policymakers? That's where he's diving in. Perhaps this goes to you, Maya, and you can address this in a final round. So I would start with Michael and then go over step by step.
Yeah, thanks for the question, Carol. Good to hear from you. And the point about transferring knowledge and working together and learning from each other, I think this is really an essential one that we can develop. And we actually have started already quite early on. And that's at different levels. And this is why elements such as the paper which was published yesterday, yes, I'm advertising it again, but I think it's a really, really important step because this is about the evidence that we have in front of us. But equally, last year you will have seen posts that we have been doing when the HTA Secretariat came to EMA and we had an exchange of how do we run secretariats. So all these elements are certainly extremely valuable, and therefore the commitment given by the European Medicines Agency's network in its strategy to 2028 to support the successful implementation of the HTA regulation absolutely stands. And that allows me just to go into a very, very brief concluding remarks. Just really looking at those in charge of a regulatory assessment and those in charge of and I use now on purpose, joint clinical assessment to avoid confusion with language here. They have similar structures, similar objectives, but then again, they're working within certain scope. And yet, I think it is fair to say there are a couple of domains where we can learn, and we are definitely engaging and sharing these. This is also why we're here today, and we stand also ready to support any work that's been done by those preparing ultimately indicators to share experience that we have in this field. Thank you.
Let me just treat you as patients. If we consider the nations who are in need of efficient drugs as patients, and as a doctor, we need tools, but we also need confidence and reliability to have them feel well. That's, I think, probably is an image that I might confer to you. I'm fairly optimistic that part of the success of the German system is reliability of the system, that the industry has confidence into the system, that it's fairly predictable, and that's only probably applicable for about half of the European countries, and all the others it's not. When we asked the EHA, the Hematology Association, who would contribute as a national societies, one of the first ones to raise their hand was Turkey, Israel, UK and Switzerland. None of them are EU countries, but there is a lot of interest to have access to that system and to get that same potentially reliable system. So as an oncologist, I'm optimistic.
Okay, so following up from the patient's standpoint, sorry, I'm going to go back on what I had said earlier. I mean, first off, before talking about success, talk about workability. I think that's extremely important. And secondly, create a system that patients remain enthusiastic about. they are enthusiastic now, they need to be enthusiastic in 10 years. So we need to make sure that they see the value. So yeah, I close off with that.
Cool. Giovanna?
I am very optimistic too. I think that the different countries will share the same method of evaluation, and this for me is very important. Obviously, after this evaluation will remain some other factors which will influence really the access. But it is important to have the same method for the evaluation of the evidence.
Maya?
Yeah, maybe I can just finish off with replying to the comment that, in a way, the whole construct of this framework is about the EU level with member states working together and then informing the national level where the decisions are going to be made. So in the coordination group members are all HTA bodies who do HTA, so there is no disconnect. So they are the ones who are agreeing on the report that then they will use to make the decisions for the reimbursement. So I think there is a seamless thing. And for countries, what's also important is that this is a learning experience for countries that don't have HTA agencies. We've already seen quite a big move. In the last 2 years, 2 new HTA agencies have been created in different member states. And in member states where they don't currently have an agency, it's the ministries of health who are involved. So this is not about like, projects on HTA. These are the decision makers. The decision makers are there speaking to each other around the table, and then we link in the patients and clinicians. So I think we are really creating a framework where all of the people who need to be there are around the table. But as you said, the proof will be in the pudding. So I want to also take this opportunity to thank you, Jörg and Elaine, for bringing everyone together, because I think it's a really inspiring discussion about what do we measure and when and how and which lens we're looking at this through. So I will take all of this back, and I really want to thank you very much for inviting me.
Thanks very much. To big applause. In the afternoon, we will dive with more granularity than in, let's say, the performance measurement, and also in the breakout sessions, we will have an opportunity to better digest all what we have heard so far. A last comment, perhaps a last general comment. I think in the current environment that we discussed frequently this morning, the global environment, it's a privilege to have this kind of open and, let's say, targeted discussion. We come together not discussing, can we get richer or whatever? We come together in order to clarify what do we do, what can we do, optimize with scarce resources. So doing it right, I think that's bringing us together, and that's a privilege having this discussion and the opportunity.